Welcome, everybody, to today's webinar about COVID-19 therapeutics today and what we need in resource-constrained settings. My name is Patty Garcia, and I am a professor at the School of Public Health at Cayetano Heredia University in Lima, Peru. And I am also a member of the steering committee for the COVID-19 Clinical Research Coalition, which organized this webinar. To date, the few medications with proven effectiveness in COVID are appropriate primarily for the treatment of severely ill hospitalized patients in well-resourced settings. And although WHO had recommended the use of monoclonal antibody treatment for people with early-stage COVID-19, those treatments are too expensive and complex to use in resource-constrained settings. And there are no proven medications for uncomplicated COVID that could be widely available in countries like mine, in low middle-income countries. So we have 5 experts with us today who will summarize where we are currently with COVID-19 in terms of the new and emerging medicines, what is actually needed in clinical sites in low-resource settings, the impact of recent clinical results on our current research and our current research priorities. And very importantly, what can be done to ensure that everyone has access to proven medicines to treat COVID-19. Actually, this is a problem that we have been all suffering in our countries. So the fact that we didn't have medicines or they were not based on evidence. So this webinar has been organized by the COVID-19 Clinical Research Coalition, and the coalition was formed in April 2020 by clinical researchers and scientists in response to their growing concern about the impact of COVID on health systems around the world and the need of clinical research that will respond to the priorities of low resource settings. You can find more information about the Clinical Research Coalition in our website, covid19crc.org. Also, next slide, please. The coalition is in the process of developing a COVID-19 therapeutics core working group. If you are an expert in this field and are interested in learning more about this new working group and potentially on how to get involved, you will find a link in the chat for more information on the group and how to apply. So now, let's start our webinar. We are very fortunate to have a great deal of research and clinical experience represented in our expert panel today. This is the agenda. We are very fortunate. Well, following these presentations, we will have a roundtable discussion with all the panelists and an opportunity to answer your questions. So I would like to start by having some housekeeping notes. The next slide, please. This is a webinar that is being recorded and will be posted later on the coalition website, so you will have access to it. Please ask questions via the QA tool at the bottom of your screen. You can also upvote people's questions by clicking the thumbs up icon. If you would like to address a question to one of the speakers in particular, please be sure to include the speaker's name with your question. And finally, at the end of this event, you will be asked to fill out a short survey. We hope you will participate to help us improve our future webinars. Now, I am going to introduce our first speaker, and I would like to remind speakers to keep to time, please, to ensure we have enough time at the end for the roundtable and a discussion and the Q&A session. So it is my pleasure to introduce Dr. Ludovic Reves. He is the Regional Advisor on Health Research Management within the Department of Evidence and Intelligence for Action in Health at the Pan American Health Organization. He also coordinates the clinical management team from PAHO Incident Management System that was activated to provide direct emergency response to health ministers in different areas. So thank you so much for all the people that are attending this webinar, and go ahead, Dr. Ludovic. Thank you so much.
Thank you very much, Patricia, and it is a pleasure to participate in this webinar. And hi, everyone. So, first of all, I'm really sorry because I'm going to present a lot of information in just 10 minutes. So sorry for that, but the idea is to present kind of a summary. So there I have three main objectives. The first one is presenting how we are synthesizing the evidence here at PAHO. Secondly, presenting what are the recommendations, WHO recommendations, but also the PAHO recommendations, which are contextualized and aligned mostly with some of the recommendation of WHO, and then discuss some consideration for the implementation in countries. So in April 2020, we started with this PAHO Living Review of Potential Therapeutics, and we started with this because we anticipated that there were going to be a lot of studies and clinical trials, and our member states were going to have questions every day regarding therapeutics. At the beginning, we started with in vitro studies, and then we got into observational studies, and then right now we are focusing more on clinical trials, randomized controlled trials. So this is the ongoing living review that we have been published every 3 weeks. We have now 32 editions of this that have been published. These are very quickly the methods. So we use the LOVE repository of Epistemonicus that has more than 50 different databases, and we are sure that we are really identifying all the published studies and studies that are on preprint, press release. And we also have frequently have access to unpublished literature as well. Once we identify the studies, we evaluate each one of the included studies, we extract the information, we evaluate the risk of bias, and we conduct all the meta-analysis for each one of the different interventions. And then we use GRADE as a methodology, sorry, in which we evaluate a number of criteria. I won't get into the methodology, but just to let you know that we are following this rigorous process. And at the end, we summarize the evidence, not only with the meta-analysis and the information for each one of the studies, but we also produce these tables that are the summary of funding tables in which you can have the relative effect of the interventions for each one of the outcomes, and also the absolute effect estimates, which are really important for them making the recommendations. So this is a summary of what we present. So this is a table that we produce for each one of the outcomes and for each one of the interventions. In the first column, you have the number of studies for each one of those interventions. Right now, we have 175 in the one that is going to be published today, 175 interventions, and we have 529 randomized controlled trials in that are including this table. And we classify this based on the certainty of the evidence, as if the intervention has some effect for each one of the outcomes, if he has no significant effect, if he has some harmful effect, uncertain effect, or no evidence or no estimate. And this is kind of a general summary that you can oversee for all those recommendations. You can see that most of them really don't have enough evidence, and that for some of them have some effectiveness, some benefit that we can receive. So this is kind of a big picture, but then if you get into the publication, you get the data for each one of this intervention and all the tables for those. Then based on this ongoing review, we produce our own clinical management guidelines for mild and moderate disease and for clinical and critical ill adults. And our colleagues from WHO, they have also a process in which they develop their guideline, and we are aligned with the recommendation as well. So I'm going to now get into the some specificities regarding the therapeutic of severe and critical disease. So these are some of the medications that are currently recommended in PAHO guidelines, and there are some additional that are recommended in WHO guidelines, which are steroids, tocilizumab, baricitinib, and Regencov.
Ouais.
Sorry? Okay. And so for this, there is less controversy, and the only thing is that Regencov, there is some studies that prove there is not much effectiveness with Omicron. So I'm not getting to this in so more detail as I'm going to get into the next one. Also, so these are the current recommendations that we have, that WHO has, and as I said, we have following the same, and we are recommending against the use of remdesivir, convalescent plasma, ivermectin, hydroxychloroquine, and some others. But the previous one are kind of the one that we are recommending in the region, but they have, of course, as Patricia has mentioned, particularly tocilizumab and baricitinib. They have some access issues that WHO is trying to address, giving access to those, particularly right now to tocilizumab. For non-severe COVID, here there is some more difficulties in how to really identify the groups that are going to receive this medication. So this is the evidence that we have for monoclonal antibodies, for antivirals, and for other medications. Right now, WHO is recommending Trovimab and Regencov specifically, and is developing a recommendation for molnupiravir, Paxlovid, and fluvoxamine. These are currently being developed and are going to be available soon. As you can see, there are some difference because all these studies were developed in unvaccinated population with a different risk. And so the baseline risk and the effect that you can see is around 3 to 4 per 100 persons. So this is the risk that we'll see right now. But this risk is, of course, lower for unvaccinated for vaccinated population, even if they have high risk. And so these medications then we need to prioritize better this medication for these groups that are vaccinated. And of course, there are, with Omicron, some of those medications have less effect, in particular monoclonal antibodies, and for the others, it seems that they're still working in the same way that in the previous studies. So these are the current recommendations. I'm not going to get into that because of time. And I would like to focus more in this last slide that I have, which is, this is something that was developed by the National Institute of Health. Is in this in this group of high risk population, you have to select what is the population that is going to receive those medications that have for non-severe disease, and they have then created these 4 groups. The first one is immunocompromised individuals not expected to mount an adequate immune response to COVID vaccination due to their underlying conditions. And then unvaccinated individuals at the high risk of severe disease, anyone that is aged more than 75 years or anyone aged 65 with additional risk factors. And a second group, which is unvaccinated individuals at risk of severe disease, not included in the tier number 1. And we had a panel with a discussion with our panel here at PAHO, and they considered that for our region, these first 2 groups are probably the one that will benefit more of these new medications. And this is kind of some consideration that we are providing to our member state on how to better select which medication should receive this specific medications. Because as I said, all vaccinated populations have a really low risk, and if you consider that around 3 to 5% are going to benefit from the medication in unvaccinated population, that risk is really lower, at least 10 times lower for vaccinated population. And so, of course, then you have to make a decision if you really, based on the constraints that you have, the difficulties in getting those medications, given that we have in the region problems in some countries, or particularly in some specific settings in some countries, with oxygen, with lack of beds in some cases, particularly in the previous month. Then you have to better really establish how to really get these medications. So this is what I wanted to present, and of course get into the discussion with my colleagues later. Thank you very much.
Thank you so much, Dr. Reves, for your presentation. And now we have to go to the second speaker. Dr. Jeremy Nell is a medical doctor, and he works as a specialist physician and infectious diseases specialist at the University of Witwatersrand in Johannesburg, South Africa. He is also a member of South Africa's COVID Clinical Guidelines Committee and has been the co-national principal investigator for the WHO Solidarity Trial and the Recovery Trial, among others. And so welcome, Dr. Jeremy Nell, and you can turn on your audio now.
Great, thank you very much. And it's a pleasure to be able to speak to you all today. So I'm going to talk a little bit about where we are with therapeutics from a South African perspective, which is obviously another middle-income country. So, oops, let's go back one. So the pharmaceutical interventions, I think, are well known through the world. This is more or less the spectrum that we have available across the world, and there will be some differences by country, but this is roughly where we are. So we've got post-exposure prophylaxis and or early intervention, and really the only option for post-exposure prophylaxis might be monoclonal antibodies, and I've given there the ones that the FDA happens to approve, but it's more commonly used as early intervention. So really the monoclonal antibodies there would be given potentially early on to high-risk individuals to try and prevent severe disease. Then there are an exciting new class of agents, the oral antivirals, of which, for example, molnupiravir is one of the classic examples. There's now Paxlovid as well, which is coming on the market, and these offer opportunities to provide people therapies early on, again, to try and prevent severe disease and hospitalization. And then I've put remdesivir in there rather than treatment for severe disease, following on WHO's lead really with the Solidarity Trial. I don't think it has a huge role in the treatment of hospitalized patients, but it does recently potentially have a role for early intervention earlier on in the disease cascade to try and prevent hospitalization. And then, of course, as we move to severe disease, we know that corticosteroids have a very important benefit to play, and this was a huge victory when the world worked this out, saved a lot of lives. And then more recently, tocilizumab, one of the monoclonals, and baricitinib as well, which is another agent which really does seem to reduce mortality in the severely ill cohort. In other words, those potentially who are hospitalized and requiring oxygen. And that's roughly the spectrum. But now what do you have in a country like South Africa, for example? One of the big problems is the monoclonals. And as was said in the introduction, these are a nightmare. These are theoretical drugs more than practical drugs in a low and middle income setting. And that is because there are a number of logistical hurdles which are really big barriers to this at scale, at least. For example, we know that these monoclonals are intravenous drugs. There's no oral monoclonal tablet, for example. These are all intravenous drugs. These all need to be infused, and they need to be given in centers where this can happen. But that's also a problem because you need staff in those centers. And we also remember if you're treating early patients early on in the disease cascade, that's where they're the most infectious. The viral load is the highest. And so that's another problem. It's not just an infusion center. You need an infusion center where you can protect the staff as well from catching COVID. There's often quite important cold chain restrictions on these monoclonal antibodies. They're not easy to handle and store. Access to them is an enormous problem because they are limited in the way that, in the amounts that are produced and are available to low and middle income country settings. They're expensive, as was mentioned again in the introduction. And then in general, for example, in the WHO's guidance, they really are given really for those who are seronegative if you're giving them for treatment, which is another hurdle, because how do you know someone's seronegative? You have to do an antibody test and find that out very soon, and you have to have a rapid turnaround time. So they're enormous logistical hurdles, and even in highly resourced countries, they're difficult, but in a low and middle income setting, they're very, very difficult and really not given at all at scale to the majority of the population. Another big limitation to them, and why I'm not hugely optimistic about them as a class, is that so far all of these are really targeting effectively the spike protein. And as new mutants come along and as new variants come along with SARS-CoV-2, they often knock out the efficacy of these monoclonal antibodies. And so, for example, we've seen with Delta, only some of them worked, and with Omicron, even fewer of them worked. And I think this is going to be a recurrent problem. We know that the spike protein is really the focus of evolution for most of these viruses. And I think it's going to be a constant hurdle to try and catch up these monoclonals. Regardless of whether that's true or not, it's certainly not a practical issue in the low and middle income settings for the vast majority of people. What about some of those oral antivirals I showed? So I'm a big fan of the oral formulation. As you can see, they're much better logistically. It's very difficult to give these medicines if they're intravenous, but orally is the way to go. We do have the problem, of course, of identifying people early then, because if you're waiting for them to hit hospital, that's good for the hospitalized treatments, but these drugs you want to be giving early before they get to hospital. So you have to identify them, ideally within 3 to 5 days of symptoms. Really, after that, they don't work nearly as well. And then there's individual problems with each of the drugs so far. We know with so-called Paxlovid, nirmatrelvir and ritonavir, the ritonavir especially leads to a lot of drug-drug interactions. So there's a lot of contraindications to these medicines. With molnupiravir, the efficacy seemed a bit less once the final publication came out, which means that there's some pretty strict cost effectiveness calculations that you need to do if you're in a low and middle income setting. We know access is going to be a challenge to these drugs. With molnupiravir, at least there's some generic manufacturers which have been allowed to make this drug. With Paxlovid, it's going to be harder in terms of access this year to low and middle income settings. Seems very, very limited. And then one consideration for countries, as well as the so-called indication creep, that we know we're supposed to be giving this to high-risk people. In other words, people who have mild disease early on in their symptoms, but who are at high risk of developing severe disease. But that's a bit tricky because, for example, if you give this at local clinic levels, we know from experience with other drugs that they get used for far more scenarios than they should be. In other words, maybe someone comes in after a week of symptoms, but they'll still get the drug. Or maybe they're not that high risk, but they'll still get the drug. So whatever you budget for is often exceeded in the real world by so-called indication creep. In terms of inpatient therapies, we got lucky with steroids. This is something to thank your lucky stars for, because these are cheap, widely available drugs, available in multiple formulations, which are pretty much equivalent, we think, at least or close to thereabouts. And they have a big effect on mortality. This graph there is from the WHO's living guidelines, and you can see that per 1,000 people, the estimate is that 34 fewer people will die if you give everyone steroids. So it's about a 3.5% reduction in mortality. In absolute terms, that's actually, and as relative terms, it's big. And for anything, by any measure, that's a big decrease in mortality. And so we got lucky because these are available in every country. We know they're cheap. We know everyone can use them. And this finding from the recovery trial has probably saved more lives than anything else, apart from vaccination, of course, which is now the dominant way to save lives. But certainly before vaccinations, this was the number one thing. Tocilizumab, we know works as well. We don't doubt that. That's been reviewed extensively by WHO and by other organizations, and found that it does have a small mortality benefit. The mortality benefit's a bit smaller. Access is a difficult thing, and cost is a problem, especially if we look for us. For example, we actually in South Africa did do cost effectiveness calculations and found that for our particular setting and our particular government, it really was not cost effective to be using tocilizumab at the price we were able to access it to, even though we agreed that it works. Baricitinib is another drug. It's an oral drug there that you can give. The cost for us in South Africa is probably about a half to a third of the cost of tocilizumab, and the efficacy, the size of effect seems similar. So we've actually gone the route in South Africa of promoting baricitinib over tocilizumab for the state sector, The private sector, where cost is less of an issue, if you can afford it, you can have it. They use a lot more tocilizumab at the moment. So that's really the range of where we are. One important thing, and it was really covered by our first speaker, but so I just really want to be really brief here about this, is just that it's really important and difficult, though, to find the right strategy for your own country. South Africa did what South America did effectively by going through this tidal wave of evidence and putting together an expert team of evidence-based medicine experts, physicians, pharmacologists, and looking at the evidence as it came through and trying to adapt it for the Southern African setting and the South African setting in particular. Again, using this grade methodology of formulating the question, garnering the evidence, assessing the evidence by grade criteria, and then formulating recommendations that followed from the evidence in a really as transparent a manner as possible. This takes a lot of work, though. It requires a lot of expertise and a lot of hours. And so it's really important that you make sure that we try and not duplicate this work. And looking at, for example, what's already been done in South America, that this really is a call to get this done across the board. WHO does a lot of this work already. So finding the right strategy from your own country. So we feed this evidence into our own guidelines. These are publicly available. We put all of the evidence summaries available on the website within a day of them being completed, so that anyone can review them, critique them, and give feedback if they disagree, so that we get this as transparent as possible. We update the guidelines regularly, but how to update that regularly is difficult. As you know, with all the new papers, it's not always clear when you need to update a guideline, and versus when you can wait for a more practice-changing trial. And then, of course, publicizing them through webinars, articles, and training. And that, again, is an important part. We've seen a lot of gap between the knowledge and actually the action. And that's always the issue in terms of translating what the evidence suggests into practice on the ground. And so really, this is just the last slide. This is a particular, I don't mean for you to read the small print here, but this is really just to show you where we are. In South Africa at the moment, we recommend corticosteroids, obviously in the appropriate people. This is for hospitalized people requiring oxygen. Heparin at prophylactic doses, not therapeutic doses, and baricitinib for those, again, who require oxygen. There's a lot of drugs we recommend against. And sadly, we recommend against tocilizumab in South Africa for the state sector, given the cost, because of the cost effectiveness. Don't doubt that it works, just that the expense is too much for our state sector, although it is available in the private sector. So I hope that's given you a sort of flavor of what we do in South Africa and what may apply to other middle-income countries as well. Thanks very much.
Thank you so much, Dr. Jeremy Neal. It's so nice to see how you have organized in your country this group of experts, and you have decided or are deciding therapeutics based on evidence and not based on eminence like has happened in other countries in South America. So now is the turn for Professor Samba. He's a former Minister of Health from Mali and currently Director General of the National Institute of Public Health, also in Mali. Dr. So has recorded his presentation because at short notice, he had to visit a clinical site and he's not sure about the connectivity in his current location. However, he's going to try to join us, and actually he's right now with us. So he will be able to answer later on any type of questions in person. So welcome, Dr. Samba. Thank you so much. And we're going to hear your recording.
Thank you for the invitation to speak with you today. As we know, the impact of COVID-19 has extended to all parts of the globe. And while we have all undoubtedly been affected by the pandemic, there is a little doubt by now that it is the poorest and the most marginalized in society that have been hit hardest, both in terms of life and livelihood loss. Many low-income countries like Mali started the pandemic with fragile and under-resourced health systems and Needless to say, 2 pandemic years have not been at all kind to them. African continent has to date been critically under vaccinated. Hopes for an equitable distribution of vaccine stocks have not yet been realized. So now, increasingly, attention is turning towards oral antiviral treatments. These treatments, in conjunction with safe and effective vaccines, offer the possibility of relieving the burden of illness and death on under-resourced healthcare systems and fragilized communities alike. It is a good time, therefore, to look critically at the opportunities that different treatments offer to African countries and the challenges that these countries may face in obtaining and administering therapeutics. The need is, of course, painfully apparent. While vaccines remain the best, most widespread defense against severe COVID infection, less than 10% of the African population have been fully vaccinated. More than that, we cannot even be certain of the true spread of infection in our countries. While it is true that known cases and mortality rates in Africa are lower than in the rest of the world, we can be all but certain that true rates of infections and severe disease are significantly higher. And in a context of fragile health system, this means that those who do contract COVID-19 and become critically ill are more likely to die than in other countries. We fully expect this to become even more marked as new variants of concern, such as Omicron, emerge. In the context of variants, potentially more transmissible and more deadly than those we have seen until now, treatments and therapeutics have a critical role to play in minimizing the impact of COVID-19, not only for Africa itself, but the whole world. If treatment can keep patients out of hospital and reduce the need for oxygen or critical care, facilities that Mali and other similar countries have only in very limited supplies, this will have a twofold benefit. In the first place, healthcare workers and the health system more generally will be released, at least in part, from the burden of disease, and this will allow for time and resources to be spent on other essential services. It will also directly reduce morbidity and mortality as a result of COVID-19. Already in Mali, and after years of relative decline, we are seeing increases in maternal and child mortality. And this is a direct result of the impact of COVID on more routine services. COVID-19 is deadly and destructive in and of itself. It also has the potential to reverse all the hard-won gains and improvements of the last decade or so. This would be truly disastrous. The good news is that so far, oral antiviral treatments are proving to be effective even in unvaccinated populations, with most of the African population having no protection whatsoever against COVID-19. These pills could yet prove to be a lifesaver for high-risk unvaccinated patients with mild or moderate disease. The great advantage, of course, and unlike more invasive treatments that require injections, is that oral antiviral treatments are easy and quick to administer and can be taken at home. They also require less medical supervision, even if assessment by a medical professional is needed to determine treatability for treatment and to provide information about the medication and how to take it. This last point is likely to be crucial, as absolute adherence to dosing instructions is a vital component in reducing the possibility of resistance to medications. The other great advantage of these therapeutics is their cost. Over treatments for COVID-19 that are becoming available, such as monoclonal antibodies and antiviral drugs like remdesivir, are more expensive. In countries where health budgets are always stretched and where underlying structural problems undermine national government's ability to act, these new treatments arrive with the promise of making treatment for COVID-19 equitable, at least, while also and simultaneously relieving pressures on overwhelmed health systems and personnel. As in the case of vaccines, however, all this is, for the time being, highly conditional. This opportunity can only be seized if African nations are able to ensure adequate supplies of the treatments in question. Some of the most pressing challenges to their successful use are the same challenges that we have faced since the beginning of the pandemic: access, testing infrastructures, and the time between testing positive and administration of a treatment. On top of this, while be the requirement to monitor resistance to treatments and all over indirect effect of the availability of treatments, I find myself in a situation similar to that in which I have been throughout the whole of the pandemic, one of cautious but hard-headed optimism, because the main issue will be equitable access to these medications, just as it was in terms of vaccine supplies. Africa has so far been under-vaccinated, not because of a lack of will or an inability to administer shots, but solely because of limited supplies. I sincerely hope that this will not be repeated when it comes to oral therapeutics. I thank you.
Thank you so much, Professor Samba. I have to mention that Professor Samba also is the Director General for the Center for Vaccine Development in Africa. And we hear you. In Latin America, we are also concerned about the issues of inequities, the fact that we do not produce the drugs or the vaccines, and the problems on the delay on our countries to the access, and we don't want that to happen with therapeutics. So now our fourth presentation, it's going to be given by Dr. Natalie Straub-Workhaft, who works at DNDi since 2009 and first as medical director, then as neglected tropical diseases director, and she's currently the COVID-19 response and pandemic preparedness director and one of the architects of the anti-COVID clinical trial. So the floor is yours, Natalie.
Thank you very much, Patty, and thank you for hosting this webinar. So yeah, I'll try to complement a bit what's been said before, starting with the fact that it's very complicated, as was said before, to understand which are, where's the evidence, what it's based on, is it consistent across all the countries and the institutions. However, we should, I think, agree that treatment guidelines, which are the way that countries make a decision, should be easy to identify. They should be developed from the results of well-conducted studies. They should be showing results that are based on agreed scientific methodologies, criteria. They should be responding to therapeutic needs that should be led ideally in target product profiles so that you know exactly what you're looking for. They should be, and that's been said before, transparent, robust, and consistent across regions, unless there are some really specific reasons for not being so. So sorry, this is the previous slide is obviously not to look at the details, but just to look at, since the public health emergency was declared in March 2020, there has been on top WHO recommendation. In the bottom, you can see some of the EMA regulations. Based on this, you can see there's not a lot of green. There's some orange, which means conditional use. There is some red, which says, no, don't use it. And if you look at the top and the bottom, it's not always aligned. It's not aligned always in content. It's not necessarily aligned in timelines, which makes things very complicated. And you can't see, I'm sorry, but there's an extract from a recent update from the FDA on outpatients recommendation on one side with remdesivir, which was not recommended before, and on the little box on the left bottom side is the only approved generic molnupiravir drug, which was approved very recently in India. So all this doesn't make it simple. But if we want to try and see where we are, that's been said a bit before as well. If we look at the spectrum of the disease, I think we can agree that monoclonal antibodies, not the cheapest, are the ones that have been approved for post-exposure prophylaxis. We have monoclonals and new antivirals for the mild, the bulk, the majority of patients, those that are outpatients that for which we should prevent progression. Here we have the new antivirals, I'll speak about this, and for the more severe patients, we have steroids or monoclonal antibodies. However, all of those, and sorry, I'm repeating a bit, but are limited either by cost for monoclonal antibodies. Someone asked in the chat how much. If you look, it's about $600 to over $3,000 per course, which is really high. Although MSF published a note saying that the monoclonal antibodies cost could be really lower. So, 1.2 for the last presentation. The mode of administration, the route of administration is IV for most of these monoclonals. So obviously not suited, as was just presented before. We don't know really well how sensitive they are against the variants, or we already know that they are not going to be effective against Omicron. We don't know about the resistance potential of those drugs. So a lot of remaining questions. So here, this is what the plan for the WHO Living Guidelines review looks like in the coming months. So they will look at anticoagulants probably for severe hospitalized patients. They will assess molnupiravir, although, so you can see the guideline should end in February, mid-February. It's been registered 3 months ago, approved in the US and 2 months ago, and Europe and other countries. They will look at nirmatrelvir, ritonavir by end of March, and fluvoxamine, there was a note in the chat, is coming for recommendation by the end of March. So again, a bit of new things coming, but not really aligned with the other regulatory approval. So 2 words on the recent ones. Nirmatrelvir, this study and the map shows you again where the study were conducted. So it's quite clear that there are some regions of the world which were not covered by this, by the clinical studies. So here the route, the mode of, the mechanism of action is it's a protease inhibitor. It's been given by three tablets twice a day for 5 days. And the study design was quite standard randomized in high-risk patients. If you look at the results, sorry, it's a bit busy. And just a note to say that to get the information about this study, the only source of information I found was on the EMA website. And I've put the source here for those of you who want to look at the very detailed and interesting and important information about this drug. So you can see here a clear effect, 7% events in the placebo arm versus 0.8 in the active arm. So a clear effect, very clear. That's it for this one. And it was well tolerated, but it has a potential for drug-drug interaction. Molnupiravir, which we've all heard a lot about, is given as 4 capsules twice a day for 5 days. Again, the map shows where it was tested and where it wasn't tested, and the primary, the design, which is standard. In terms of results here, and this is interesting, the results were very good when we looked at the first batch, the interim results on the left. So we had 14% events in the non-active arm versus 7.3% in the active arm, so a clear 50% reduction. And then when they looked at the population that was enrolled in between before the full data set, the event was very different, 4.7 in the placebo arm and 6.2 in the active arm. So obviously at the end, when you pull all of this, the remaining effect was about 30%, 9.7 versus 6.8, which is not as fantastic as we had hoped. So that's one. This came from the FDA, by the way. So you can see the very detailed information about this drug. No time today. Well tolerated, but as we know, a potential for mutagenicity through its viral change, genetic material change, and so a risk for the development potentially of resistant variants, which is a concern, and the fact that you need to give it with contraception for men and women up to 4 days after treatment. So maybe not so, fantastic as we had hoped. The last one, which has also recently been approved by the and added on the WHO guideline, is Trovimab. It's a monoclonal antibody. It is given as a single IV infusion over 30 minutes. For now, it's been tested as an intramuscular one. The study, again, geographically, same regions. The design is mostly the same. And the results were quite good, with 7% events in the placebo arm versus 1% in the treated arm. So quite interesting. This study was published. Note that the results here were based on interim results, as the same for Paxlovid, whilst the recommendation for Molnupiravir were based on full results. So if we want just to summarize, where are we with the patient population? What do we, who has been studied in those studies that resulted in guidelines? So first, are all studies published? No, at least I couldn't find them. The Paxlovid data are not yet published, maybe because they are interim. However, do we want to discuss this because guidelines were made based on the interim? I think, unless I'm wrong, the Molnupiravir studies in India, you know that 5 generic manufacturers conducted study were not published. The US-based MSD study was published. Age group, no children. Symptom onset, very important, mentioned by Prof. Samba just before. All of them show efficacy up to 5 days of symptom onset. We think that it's probably not enough, especially considering access to diagnostics. So what happens next? Did they include vaccinated patients? No, all of them excluded vaccinated patients. In one of the study in Nirmiltravir, they had a 50% seropositive patients. Still, we don't know if it would work or not. So a question, did they include immunocompromised patients. In the molnupiravir, they had 1.8% active cancer patients. In nirmatrelvir, they allowed this. They had 8% patients, but the EMA report says that this is not enough, as you can see, poorly represented, making difficult to conclude, and no in the Trovimab studies. The variants that were tested were mostly Delta. Those are studies that were conducted during summer or a bit before. Do they do post-COVID follow-up? Because this is also important. What happens after? Does it prevent the occurrence of post-COVID? What happens? We don't know. And maybe with Trovimab, we'll have some data. So you can see some gaps. So in conclusion, I think we can agree that the access to the recent evidence is not easy to have. So it's difficult for anyone to make a solid, to have your own evaluation. The regulatory opinions and the treatment guidelines are not fully aligned, to say the least. The criteria vary, and sometimes they are not relevant, such as looking at mortality as an endpoint to drive recommendation for outpatients. There are, although still promising innovative treatments for outpatients, but unfortunately not yet suitable to all settings. The access to the new compounds for clinical research is limited to the originators for the new chemical entities, except for molnupiravir for now in India. There are still, and I think I'd like also to insist here on many therapeutic gaps. What happens to patients after 5 days of symptoms? How generalizable are those data? What happens? How do you treat vaccinated patients? How do you treat immunosuppressed or compromised patients? In Africa, sickle cell or HIV positive patients, for example. How do you treat pregnant patients who are the most at risk of having very severe outcomes, including for at the delivery? What about children? What about post-COVID? Do we need to treat, can we treat asymptomatic other than with monoclonals? And what about the efficacy with resistant strains? So I think still quite a lot of questions. And then to say that, not to be pessimistic, a little bit different from Prof. Samba, but still I think the access is not yet there, either because it's limited geographically, because of the cost of those treatments or their route of administration, maybe also because some populations will have contraindications or will need to be on contraception. Will it be possible for everyone, everywhere? And there are some potential for DDI. So to conclude, I'd like to say that we feel there's still a really high pressing need, first to access those compounds that do have a benefit for high-risk patients, but also to test them, to continue to test new compounds and to test repurposed drugs. Again, some were mentioned here. I did not mention inhaled budesonide for sake of time, and also because it's not part of the guidelines, to simplify. But we need treatment options that will work for, simple, feed-adapted test and treat strategies for all the population at risk, especially in low-resource settings. I think I'll end here. Thank you.
Thank you very much, Natalie. That was really great. Trying to put together everything that we have heard and to think about what are the missing links, what is still needed in the research, what do we know and what we don't know yet. So that was great. So that leaves us to the next speaker. So if we have some medicines working, how can we assure people get them or we have the access? And for that, we want to invite Ms. Lina Meganey, who is a lawyer and the Global IP Advisor with the Access Campaign at Medicine Sans Frontiers, Doctors Without Borders. She works with other experts and in partnership with patients groups and civil society in the Global South to increase access to affordable vaccines, medicines, and tests in low middle-income countries for several diseases like HIV, drug-resistant tuberculosis, hepatitis, cancer, and nowadays also with COVID. So thank you so much for being today with us, Lina, and the floor is yours.
Thank you for having me. Thank you to the Coalition for inviting MSF Access Campaign to join this discussion. So one of the key things that I wanted to sort of highlight is that, some of my learnings and knowledge have come from the Delta wave that struck India in April 2021. And we saw people struggling to access treatments. And of course, secondly, I work with Doctors Without Borders, and we set up a project to treat COVID during the Delta wave in the northeast of India, in the state of Manipur. And thirdly, of course, I have colleagues who are pharmacists and medical experts who have been, tracking some of what you all have been presenting. So the knowledge is not all mine; it's coming from that experience, and I'm going to speak to that experience. So, deaths are just statistics. That's, every day when you open the newspaper, it's about the number of deaths. In India, we've been privileged enough to have access to vaccinations quite widely. And not only just the first dose, but the second dose. That's largely due to the manufacturing capacity that India has. And I'm not going to go into the politics of what happened on vaccine exports. But I just would like to highlight that what we saw in the Delta wave was really clearly something that strikes you even now when you open the newspaper and you look at deaths. One is that you have people at risk who are at risk of developing severe disease, and they need drugs to prevent them from progressing to the severe stage. A classic example, for example, would be I got COVID, my mother-in-law got COVID, and the doctors are very keen to put her on antivirals. So there is obviously some scope of triaging people who get COVID and at risk of becoming severely sick. And then, of course, you have people who actually are hospitalized. And even during this wave of Omicron, hospitalization has gone up. And if you look at the Mumbai Authority figures, they've just sort of said about 12 to 18% patients progress to severe disease. So you have people in hospitals or moving towards hospitalization who would need the drugs to prevent them from getting critically ill. So there's no doubt that vaccines are not the only tool to fight COVID, and we really definitely need to progress to looking at having the guidelines, but also drug access in place for people who need the treatments that they have. So firstly, on the testing strategy, and I just wanted to sort of highlight that governments need to put in a lot more effort in communicating and working with community-based groups to highlight the people most at risk of severe disease, so that people reach testing services quickly. So you need testing tools which are community friendly, but you also need the IEC to put the word out in community-based organizations who work on health and communities themselves that there are people who are particularly vulnerable and they need early testing, and testing should be, of course, available free of cost. So that's my first point. The second point I wanted to highlight is this, that every time you have a therapeutic coming along, you have a situation where the pharmaceutical corporation decides who gets it at what price. So you've got monoclonal antibodies, and Roche, of course, stands out in that line. In the state of Manipur, when we were treating COVID and, of course, the severe cases of COVID, we had oxygen, we had the hospital set up, we had staff, we had everything that we needed, except for the drug that was most needed, which was tocilizumab. So even in resource-poor settings where capacity to use tocilizumab existed, tocilizumab was not available. It's extremely expensive. And of course, the lack of a biosimilar strategy, or I would say biogenerics, is obviously telling in this pandemic. Many of us have known about the situation of poorer people dying due to other diseases due to lack of access to biological drugs. You look at trastuzumab for breast cancer, that stands out as a clear example that we've got a long way to go on access to biological drugs. Moving on, I would just like to sort of highlight that as we have baricitinib, JAK inhibitors coming into the guidelines, luckily to substitute tocilizumab, and we have, of course, the oral antivirals coming in for mild and moderate cases who are at risk of severe disease. And I think two things stand out on the access front if we want people to be able to access these drugs. With baricitinib, I would just like to sort of highlight is that the one advantage resource-poor settings countries have is the fact that generics exist, that the raw material to make the generics exist, the finished formulations exist. Both of baricitinib is being produced by two countries already, by Bangladesh and India. It costs just $7 for a 14-day treatment. And what we need now is quality assurance and efforts by governments to access baricitinib from the generic sources as we have them now. So if we really need to move towards figuring out access for baricitinib, I think when I saw the South African guidelines, it struck me that I hope they're not just looking at Eli Lilly as a source of the drug, that they're looking at the generics themselves. So that's something that I just wanted to sort of highlight. The second thing I wanted to talk about is the oral antivirals. And of course, everyone knows that molnupiravir was something that Bangladeshi and Indian companies invested heavily in, and there's a generic supply. But it's not as promising, and it has complexities in resource-poor settings. That leaves two other drugs for early disease, which is remdesivir and nirmatrelvir, used with ritonavir. And I just wanted to simply say this. With nirmatrelvir, for the first 6 months, we are heavily dependent on Pfizer for the drugs. And as we know in our past experience with vaccines, they're likely to go to high-income countries. So working to find the sources of nirmatrelvir and ritonavir generics and quality assuring them, including, I think one of the most important things that, perhaps we really need to think about is we need samples of the originator product, to run the bioequivalence studies. So what's the biggest challenge today with nirmatrelvir and ritonavir, or even, other drugs, is we need originator samples, which are very difficult to access to run the bioequivalence studies. And a number of companies have made a request to the active therapeutic pillar that these samples be made available to them. The second thing I wanted to highlight is that remdesivir, and we keep circling back to remdesivir, is that one way to have remdesivir competing with nirmatrelvir, and we all know about the drug-drug interaction with ritonavir, is to have oral formulations of remdesivir. Now, Indian companies have applied to the Indian drug regulator for approval for oral remdesivir. I think the regulatory pathway is unclear to the Indian regulator. And what we see is that we keep going back to discussions whether we have the capacity to provide remdesivir in its current form in resource-poor settings. So I think a lot of work needs to be done that goes beyond guidelines. And I think what really is very critical is that we create and get member states and governments and health authorities together to discuss what the access challenges are. And I think the need of the hour that, countries don't grapple PAHO and, for example, India or you have Malaysia, you have Indonesia, you've got South Africa and many other countries. They're all grappling on their own to access these treatments and figure out the guidelines. And I think getting health authorities together would be absolutely the way forward. I think looking at the generic pipeline and not just the originator pipeline is equally important. And looking at the challenges that generic manufacturers face everywhere, not just in India, is critically important. And lastly, I just sort of wanted to end on the note, since I just have about a minute left, is that you've got baricitinib for severe disease, but it's heavily patented across the world. And we really need to look at how we overcome these patent barriers, including in countries like South Africa. On oral remdesivir, I think a lot more work needs to be done. The formulations exist, but the regulatory pathway is not clear. For the other oral antivirals, specifically for nirmatrelvir, we need the originator samples to run the bioequivalence studies. So I think these are some of the things that we really need to do. And on that note, I would just simply say that we need a very smart testing strategy, early testing strategy in resource-poor settings to be discussed and sort of rolled out, because we can't afford to have people dying when you have effective therapeutics. And on that note, I'm going to stop here. Thanks.
Thank you so much, Lina. So we're talking not only about that we need drugs that work, but we need drugs where we need them. So we need the access, and maybe we need to go beyond just thinking on how to bring them to the countries, but also how countries can start producing them, developing it, etc., etc. It has been a really, really rich discussion. I would like to invite all the participants to share your questions in the QA session. I think that a lot of people have been writing things in the chat, but it will be good if they could be sure that it is in the QA session. There are also questions regarding the access to these presentations, and there are two ways you will be able to access. One, it will be directly through our website, and then for all the people that had registered, they will receive an email with the link of the videos and the PowerPoints also. So we are going now to move into the roundtable discussion with the Q&A. The roundtable discussion will be moderated by Dr. Pojani Jitamala and by Professor Nick White. There are already more than 22 questions. They are all quite interesting, so we will apologize if we cannot answer all of them, but we'll try, okay? I'm sure that Nick will do it. Pojani is an assistant professor in the Department of Tropical Hygiene in the Faculty of Tropical Medicine at Mahidol University in Bangkok, Thailand. And she's a pediatrician specialized in infectious diseases and works at the Hospital for Tropical Diseases, and is also involved in teaching and research. Welcome, Pojani. And Professor Nick White is a Wellcome Trust Principal Research Fellow who chairs the Wellcome Trust Tropical Medicine Research Program in Southeast Asia. He has lived and worked in Thailand since 1980, and his research focuses on the pathophysiology and treatment of malaria. But in the last couple of years, he has been also principal investigator for the COP-COV trial, as well as the chair of the steering committee for the COVID-19 Clinical Research Coalition. And I have to say that he's also the heart, and he has been pushing us all to think even more how to address the issues that COVID is bringing into our low resource settings. So Dr. Jitamala and Nick, I turn the floor over to you. Thank you so much.
Thank you very much, Patty, and thank you to all the speakers and all those of you who've asked questions. So Pojani and I will alternate. I'll start, and I'm going to start with a question. It's for Ludovic, but also I'd like to know, welcome others in the panel to comment. Perhaps Jeremy could comment as well, because it's about fluvoxamine. We've had quite a few questions about that. So do you think it's reasonable to give the same evidence grade and the same effect estimate to the fluvoxamine studies in early COVID and the molnupiravir studies in early COVID? A priori, molnupiravir would seem more likely to actually work. In addition, the main fluvoxamine study had a composite outcome with a highly subjective component, which was 6 hours under observation in the emergency room. The molnupiravir studies used hospitalization and death only, and they saw an antiviral effect. So it's an interesting, topical, and slightly complicated question. Perhaps Ludovic could start and Jeremy comment.
Yeah, thank you, Nick. So the information that we have, the evidence that we have is based on 2 studies, but there is an additional study that haven't been published, in which WHO is currently analyzing that data. So I don't want to really get into too much detail because it's unpublished data. So they're analyzing this data and doing the meta-analysis and doing all these tables, the summary funding tables, to make a recommendation on the medication. Based on that data, the outcome really in which you are making the decision is the hospitalization. And you will see that most of the medications are that we show, at least in those tables, are decreasing between 1.5% and 5% the risk of hospitalization as a absolute, the absolute risk difference. And for this medication in particularly is probably around 1 or 2%, but we need to, I don't want to get into the details of this data because it's unpublished data. The panel is going to review that information. They are going to make a recommendation based on the available evidence. For mortality and the others outcome, it's always more difficult because the studies have enrolled less number of patients, and the events that you have are really few events. And so mainly the decision has to be made based on what the panel considers relevant and important based on the absolute risk of the medication. So that would be my response. I'm sorry because I cannot provide the whole information because I'm not allowed to discuss this unpublished data.
Thanks. So Jeremy, you've at least must have had a look at the published information, but you're not recommending it in South Africa. Any comments?
So yeah, thanks. So we're very interested to hear there's a third study coming, which will be great, and we'll certainly be keeping our eyes open for it. But yeah, of the published data, I agree with the question. The issue of, and this is a general principle really, the issue of using endpoints that include, for example, 6 hours in the emergency department, like the Together study did for fluvoxamine, is tricky because it's very hard to translate that across countries. You know, the thresholds for emergency admission are very different. The amount of time you might spend in an emergency department is very different. Whether people even seek attention in an emergency department is quite difficult. So we struggled a lot. The paper was very nicely and clearly written, so we were able to extract just the purely mortality data from it, and that wasn't statistically significantly different to the placebo arm. So in South Africa, we're watching it closely because it came very close. It's a cheap drug. It's available in South Africa. We're very interested in it. We'll be very interested to see what the results of the meta-analysis with third trial is. But for now, yes, we haven't recommended it, although reluctantly low. So we're quite interested still in it, but it's not a recommendation given the published data at the moment. Thanks.
Thanks.
So the next question is still with Dr. Ludovic about the review of the database. Do you still want to make it publicly available for that review?
Yeah, I just put the link to the review. It's going to be updated today during the day, and we are publishing this every 3 weeks, as I said. So, and it's publicly available. And if more information is needed, we can provide the tables and whatever information is needed for that. One comment that I want to say is that we are publishing here just published studies, and those that are available in preprints, etc. But we also have some additional studies that are not part of this review. For example, I saw in molnupiravir, the discussion on molnupiravir, there are some additional studies that WHO has that are going to be, were used for making the recommendation, and that are not published here and not published in some other reviews. And that's why sometimes it takes more time to make this recommendation, because you have to get all this unpublished data, and then do the meta-analysis, then re-ask some questions, and put everything together. And this is part of the work that the group of my colleagues in WHO that they are working on.
Thank you.
Thank you.
Go on, Pajani.
No, it's just okay. I'm just want to say thank you to Dr. Ludovic before I just hand it on to you.
Okay, so here's one for, I'm going to share this one around the panel because it's not something that was addressed, but it's a popular question. On what evidence is chloroquine excluded as a preventive drug? Natalie, do you want to start on that one?
Yes, no evidence, I think. I don't
Jeremy?
know what evidence.
I'm laughing because Natalie summarized it perfectly. We did look at the evidence. There just isn't good enough evidence for it, I'm afraid. We wish it did work, but it doesn't a bit.
Ludovic?
Yeah, no, I agree with my colleagues. And you will see there are actually 52, I think 52 randomized control trials on hydroxychloroquine. And For these
Yeah.
particular outcomes, I think there are around eight studies, but yeah, there is not enough evidence to make a recommendation for that one.
Okay, thank you.
That's the question for Dr. Neil still. Where do you believe the focus should be for low resource setting with limited capacity for drug development? Which area in therapeutics can they have a valid contribution in? This question go to Dr. Jeremy Neil.
It's a very good question, and I'm not enough of an expert in drug development really to give the best answer, but I will say that one of the challenges we've had in South Africa, both with drug development, which South Africa does do a little bit of, and vaccine development, which South Africa really didn't do until recently, although it's now started a bit with the COVID vaccines, at least in part, is that it's very difficult, firstly, the expertise to build up quickly, and most importantly, though, and even more of a barrier is the sustainability of it. It's one thing to make drugs during COVID time when there's a huge demand, but as COVID becomes, let's cross fingers and touch wood in whatever we do, as COVID becomes less of an issue in the years to come, it may be difficult for some of these drug manufacturing companies to maintain their use unless they're very good with a business sense. And like I said, I'm not an expert in that, but I know that has been a consideration. One thing, though, that's related very closely to that I do think low and middle income countries should be putting up their hands for and trying to develop is to trial the drugs in their countries. And for example, the WHO Solidarity Trial is a good model of that, which is across many low and middle income country settings and really has been a showcased what is possible in those countries. And it's really important because the dynamics are very different in many low and middle income countries to the high income settings where most drugs are tested otherwise. And it's absolutely vital to have data, even if the drug's not manufactured in those countries, to at least have data about the use of those drugs in those countries. And we've seen some very different results in Solidarity compared to trials done in high income settings in a way that's been very, very useful. So I think that's a very good bridge, if not the manufacturing, which is a little bit beyond me. Certainly the drugs and the therapeutic trials are something that many countries should be incorporated in as much as possible. Thanks.
I also want just to add up in just a little bit of my experiences also. I really agree with you that in terms of the operation challenging through a whole initiation and intervention, and also the implementations of this, it's very, very difficult and very challenging for this kind of, drug fighting method.
Absolutely. And I'm interested also, Prof. Samba, if he's got any comments about it, because he may have some good insights about this.
So go to Nick.
I'm going to ask Prof. Samba because he is with us, although we can't have his video on.
Yeah. Yes.
And
yes,
you made Professor Samba.
Yes, if you can hear me.
Yes, we hear you clearly. Yes.
Can you hear me?
Yes.
Okay, so yeah, I completely agree with these comments, and really, until we develop research in low middle income countries, and not only research for research, but research in emergency situation and take advantage of quiet moments to better prepare the war, the next war, we will always be facing these issues. So I completely agree with previous comments, and Solidarity Plus and these anti-COVID network platforms are all great examples. And that was out to me the best way to go testing drugs in Africa and low middle income countries, and trying to implement them stepwise and do more and more demonstration studies so that we can really, really handle a lot of issues, lot of unknown science, medical and public health, and community-based informations and issues will be learned early enough. Thank you very much.
Thank you, Professor Samba. And I'd just like to follow up with another question to you in your capacity as former Minister of Health. I mean, we've had a lot of research on severe COVID, but you pointed out that the resources to manage severe disease are limited in low resource settings. And we don't have so much research in prevention of severe disease. I wondered if you wanted to comment on that.
Yes, today resource when COVID started in many low-income countries, particularly in Africa and especially in sub-Saharan Africa, our healthcare systems were already down. So with COVID, with this pandemic, we're seeing heavy impacts on everything in terms of human resources, logistics, etc. You are taking into account those bad rumors, the impact in terms of communication in our communities is hurting us. So research is being so much delayed in Africa in many kind of ways: logistics, knowledge, capacity, and perception in our communities. Those are things that are delaying research. And even, I think Natalie mentioned this, the regulatory and ethics aspects of the research operations in low middle income countries, and particularly in Africa, are still suffering. So to build and try to fix a more sustainable operation and be ready for the next pandemic or the next emergency situations, we need to maintain what we have. We need to strengthen what we have. We need to continue to work in a much more global way so that we'll be ready next time for a better global response, taking into account countries with low resources, with limited resources. This is the only way for us to go, because our governments do not have enough to fix what is essential. And I don't think that there will be enough to take care of research if we don't work together as a global, find a global solution. Thank you. I don't know if I answered to your question, but thank you.
Thank you. We've probably got time for two more questions. So one from Pojani and one from me.
So I go with Dr. Williams' questions at below. It's ล่างสุดเลยค่ะ So this is a very nice question from Dr. William Chillings to ask. I think I go to Dr. Ludovic, and Dr. Natalie can answer also. Dr. Revis showed nicely that there is a lack of evidence, either due to quality or study size limitations for many studies in COVID-19, in particular in the early phases of the illness. How then, with this lack of evidence, are the WHO living guidelines able to make strong recommendations about the use of many of these drugs? What effects does this have on the ongoing trials, trying to produce the evidence, and importantly, people's confidence in WHO's guideline production process, and thus the impact on uptake of future recommendations?
Thanks.
Let's go to Ludovic.
That's actually a very interesting question. So if you look at the big table that I presented with the 171 interventions, you could see that for many of those, you don't have evidence, but for some of those, you have evidence, and for some of those, you have good evidence. And so I won't say that you don't have necessarily evidence for all of those. Then, particularly in non-severe disease, because I think that in severe disease, you have some more evidence, and then you have stronger recommendation based on that. But for some non-severe disease, you will see that the WHO recommendation so far have been conditional recommendations. So there are not necessarily strong recommendation because there are knowledge that there is still a need of more evidence, or with the evidence that you have, you can just make a conditional recommendation. And this is why it's really important to follow a rigorous and systematic process, and this is why the organization follow GREAT, because it gives you all the judgments and which are transparent to make the recommendations, and sometimes you can disagree in the way that you have judged the evidence, or that you have there could be difference in the specific recommendation, but you can trace all the process, and it's a transparent process, which a panel make a decision based on the evidence that has followed all this rigorous process. So I wouldn't say that you don't have evidence. You don't have evidence for many of the interventions. You have some evidence for a proportion of those, and good evidence for few of them. And what, of course, we need some more evidence, and we're sure that there are many other interventions that are going to produce publish very soon some additional clinical trials. So we have to be prepared using the same methodology. So in that case, I would say that these guidelines are following the high standards in the development. Thanks.
Thanks. So a final question. This is for Lina. And I think you may have responded to it by typing, but I think it's an important question generally. New pharmacological interventions for COVID-19 come with an expensive price tag, as you've explained. What are the current initiatives to ensure above countries' financing lines, similar to what Gavi does for vaccines, to help LMICs to have initial access until they are organized to self-sustain the inflow of new medications? Are there any? Thanks.
Yeah, so thank you. I think what's very clear is that research and guidelines need to go hand in hand with access strategies, and that's not happening at this point in time. So I just like to highlight that, I've been working in India, and Krista's on this line. She's a pharmacist. And we've been looking at finding the generic sources of many of the drugs that are now getting into guidelines. Baricitinib is a classical example, nirmatrelvir, molnupiravir, and even tocilizumab. So I think what we need is a strategy to look at competition. And I think it's really very crucial to ensure that, it's not that, you can't make the drugs in the developing world. The question is, the drugs exist. Can we do the quality assurance in time? And can we get them into the hands of people? So if you look at molnupiravir, less than $20 for the whole course of treatment. If you look at baricitinib, $7 for a 14-day treatment. So we need to start looking at finding generic sources of these newer therapeutics. Of course, some of these are older therapeutics as well. And as Jeremy mentioned, being followed closely because of the fact that they are affordable. But for the newer ones, we need to put in an effort. And I just highlighted one of the actions that ACT-A therapeutic pillar could do was to find the samples of the originator products to conduct bioequivalent studies. Now on the issue of funding, and I think this is a very important issue. We saw the Global Fund support HIV treatment, support TB treatment, and I do think there are two elements, funding, and of course funding should be available to countries who are struggling with health resources. And number two is who organizes the funding? Is it the Global Fund or ACT-A pillar? And we can't have funds that are raised to be whittled away on patented expensive medicines. So, health budgets are tight in the pandemic. So we need to look at both the strategies, yeah.
Thank you.
Okay, so I'm afraid that our time is up, right, Professor Nick? Because this is your last questions already. So I would like to thank the panelists and the audience for the very active participations for today. And I want to hand on the stage to Dr. Patricia for the wrap up. Thank you.
Thank you so much. And actually, I would like also to thank you both for moderating this session. I would like to thank all the panelists and our moderators for this very rich discussion, and to all our audience for your questions. There are lots of questions that have been so interesting. We will keep them, because this is just, the discussion is just starting. I would like to close this webinar by pointing out 6 conclusions that at least I have gotten from all what we have heard today. So the first one is that there are new and emerging drugs for COVID, but they are far from being perfect. And I will not say that we have lost the battle, that like I saw in one of the comments there. I think there is still a battle that we need to keep fighting. The second thing is that we have realized that there are gaps, okay, that need to be filled by research. Most of the information has to do with people that are not vaccinated. We need to also get more information about how these therapeutics will work with different variants, what are the geographic differences, and those are things that need to be really answered. The third thing is that we have talked about the need of platforms for clinical trials. Examples have been given, like Solidarity, for example. But there is one thing. Most of these clinical trials have been, the ones that have included different countries, have been in hospitalized patients. And we need to work also on how to do this type of research in primary care or in the outpatient setting. And there was a comment also, we still need to understand what is going on with long COVID. My fourth point is that one thing has to do with available evidence or not evidence, and another one has to do with what countries can or will do. So how can we really translate the evidence into the implementation of good guidelines? And that had to do on how countries are working on medical training, but also access. And that brings me to another issue that is quite important. We need to think about therapeutics and also diagnostics, okay? We were talking about giving the treatment early, just based on symptoms, treating asymptomatic. So we need to think about therapeutics and diagnostics and maybe self-testing as a package. And finally, strategies of development and research should go together with strategies to assure access. And this is something that has not happened during this time, but we need to think about how to put them together. Funding, production, capacities, because treatment can be seen also as a way of prevention. I mean, it has been seen like that for HIV, so let's think about that with COVID. So this is an ongoing conversation, and I encourage those of you interested in joining the Coalition's new therapeutics working group to read the group's terms of reference and apply. You can find the link to more information about this new working group in the chat, and you have it here also, and you will receive it through email with the PPTs and the link of the recording of this session for all the people who have participated and was registered in this webinar. A survey will appear when you are leaving the webinar, and we appreciate that you taking a minute or two to fill it out. Your feedback will be very valuable, and help us to plan for future webinars. Thank you again for joining us today. Sorry we're a little late, but there was so much interest. As a reminder, this webinar has been recorded. It will be available on the Coalition's website in the next 24 hours or so, and you will receive the links in your email. Thanks again to all of you. It has been a pleasure. Goodbye.